To start things off, AI and genomics, I think that is a marriage made in heaven. The reason I say that is, to put it into perspective, a single biopsy generates 44 million data points. A whole genome sequence generates 90 gigabytes of data. And all of this requires great compute power. So I often say that biology is as much, medicine is as much as a biology problem as it is a compute problem. And I think this topic is going to answer some of the great questions in genomics, and we're going to have the next 10 years belong to synthetic biology and genomics. So to kick things off, Paul, you often talk about three aspects to a population genomics program. Could you elaborate on that and what exactly they mean?
Certainly, Sid. So when I think of these large-scale programs like the Emirati Genome Program, where there is 8/10 of the local population sequenced, and let me just make a comment that I've worked for a number of years in this space. I think this is unprecedented in terms of the size and scale of the population that will be sequenced and the implications that that might have on the different agendas, Sid, as you're indicating here. There is no doubt the potential to transform healthcare when you have the whole of a local population sequence. That impact in a clinical domain is critical. But I think there are other agendas that can simultaneously be engaged and where value can be unlocked. And alongside the clinical domain, where I'm sure there will be some examples that we can reference today, I think there is a fantastic opportunity to engage the research community from a global perspective. And the way that I see it is that the two can be interwoven together. And so if we may start with the research perspective, very often what happens in a research domain, an academic may publish a paper that would take 20 years to be translated into something that would be used at the bedside for the clinic, in the clinic. And what we'd love to see, and I think AI can accelerate this even further, is the acceleration and compression of that time scale. So let's drive and engage the research community, and let's accelerate that translational effort into a clinical domain tenfold. Let's just choose that example and demonstrate an impact within 2 years or even shorter in terms of how those two agendas can be woven together. And actually, I think the implication is that you can underpin this with what I would describe as an economic development perspective. You can actually, through getting the clinical and the economic agendas, the clinical and the academic agendas working together, you can actually stimulate economic development. Spin-outs from academia, companies that will engage in this, investment into the local community. And one of the dynamics that's emerged for me over the years is a recognition that healthcare is always delivered locally. It's within the boundaries of a country, even within a region of a country, as to how that manifests itself, how it's delivered, and what clinical impact it has. But actually, the academic, the research agenda is truly global in nature. We don't need to restrict ourselves to what sits within a country. And there's a wonderful opportunity here to facilitate that global to local translation, looking at global research impacting on a local health system underpinned with an economic development agenda that makes this sustainable for the long term. And so that's the core proposition that I'd like to put on the table that can be enabled with something like the Emirati Genome Program.
I love that. You touched on economic development there. Now, often population genomics programs have large upfront costs. Albarah, how do you think the UAE, with the help of M42, have taken the Emirati Genome Program, which is a massive cost, and turned it around into a strategic investment into health?
Thanks, Sid. I think it's really important to understand that the strategy for the Emirati Genome Program is slightly different than global population health genome programs. And the reason I say that is the majority of the world who do pop gens look at a specific cohort within their society and sequence those. And then based on the information generated from that data, they look at public health initiatives and they look into the whole discovery process and what have you. We're fortunate that we can address all of the public health initiatives, the discovery for new drugs and therapeutics for personalized medicine, but also the sequence once used for life strategy. Now, what I mean by that is that if we're able to sequence the entire UAE population, that is a genomic passport that is held with that individual throughout its entire life, from birth to death. And we can reuse this data to bring value by improving health, wellness, well-being, and reducing the costs on the healthcare ecosystem. The we are spending globally trillions of dollars on preventable disease, managing preventable disease. Our ethos is to move from a healthcare system that treats disease and symptoms of disease to a health and well-being ecosystem, i.e., we empower the patients with information. Sorry, I want to correct that, not patients. We empower our communities and individuals, because patients by default means someone who has a sickness. We empower individuals and citizens with this information to make impactful changes in their life, therefore eliminating the risk of disease, reducing the cost on the healthcare ecosystem. And if there is a disease burden, we're able to precisely treat and manage that disease, again, reducing the costs on the healthcare ecosystem, as well as improving outcomes of patients. So collectively, spending money on a population genome program is actually an investment into the population and a return of investment on reduction of healthcare costs. So that's primarily the strategy behind developing such programs.
So can I just make a quick comment on that? Albarah, I love the thinking. I mean, one of the things that struck me over the time, if we think about the entities, the different stakeholders that might engage around these large-scale programs, like government-sponsored, academic research engagement, trying to deliver clinical value through a physician perspective, maybe with industry participation centered around a patient focus. I think recognizing that each of those stakeholders may define value in different ways. You can absolutely look at monetary value in terms of healthcare costs and savings for a healthcare system. Maybe for an academic researcher, it might be about publication and kudos associated with that. From an industry perspective, it may be about delivering precision medicines into an innovative healthcare system. So recognizing what value might mean for each of the different stakeholders, and where you can quantify that in numeric terms, in financial terms, but there may be other parameters that are softer dynamics that actually are also valuable, but maybe not always in monetary terms.
100% agree with you, Paul. I think it's, Paul made a comment earlier that this is an interwoven ecosystem. And that truly is the fact, because when the research agenda typically feeds into the clinical agenda, if we're able to support the entire ecosystem with soft, quantifiable or semi-quantifiable benefits, that doesn't have to be monetary, just monetary, but also feeding the research, academia, global agenda, by default, that's going to have an improvement, both financially and non-financial as well. The strategy of a PopGen that sits as a standalone unit is just truly, in my opinion, is not a productive strategy. It has to be an integrated, augmented solution, both democratizing that information, but also integrating that information into the entire ecosystem, domestically and globally.
Hemad, go on.
Yeah, I wanted to continue the talk. Look, a PopGen is the first layer of where we want to be. And the question is that where do we want to be in application of genomics in healthcare? Okay, that's the important question. And where we want to be is be able to provide patients or individuals who require genetic reports the fastest time that we can do it, okay? When we have cancer patients who have to wait 3 weeks, 4 weeks, 5 weeks to get a NGS report, a genomics report, they don't have that much time. So we need to get the speed to result is what we need to focus on. And in order to get to that, you need Pop Genomics Perform, where you will have a baseline on which you can then identify the variants that you need to report into your clinical reports. And number two is what this guy is doing is AI. We need to bring AI and bioinformatics tool to speed up that. Once we have this ecosystem set up, then within few days of you giving a sample, you will get the reports out. That's where I think the impact at the healthcare level will be seen massively, and hopefully will help with the reduction in the cost and everything else.
Great discussion, gentlemen. I want to throw it to Javier now. Javi, the Emirati Genome Program has been going on for a few years. We've sequenced 780,000 genomes. There's a lot of excitement around it. The academic world cannot wait to get their hands on this data set. Could you enlighten us on why this is the case and why there's such interest globally from the academia around our data set?
Yeah, thank you, Sid. So I think there are many, but I will go with three because it's easy to stick around. So I think the first is the scale. I think as Paul and Albarah had mentioned, scale not only in absolute terms, 1 million, it's only comparable and even larger by now compared to UK Biobank and all of us, but also in relative terms. So we are covering the whole Emirati national, so that means that any findings that you get have immediately a nationwide impact. The second one is the ecosystem. So meaning that not only you have the genomes, but as I mentioned, the connection with Malafi, which is the clinical records, but then you have DOH not only as a sponsor, but as a body regulator that will enable research around that. And also M42, which is like a network of hospitals, which means that not only those hospitals can provide additional information, additional layer of information to EGP, but also you can roll out any insights into programs like premarital screening and others. And the third one, I think, is the Emirati population is very interesting from the genetic point of view. Not only they have very extensive and consanguineous families, which means that you can have a look from a different completely perspective that you could not have maybe on Western families. And also the fact that we are bringing into the pool of genomic studies, we are bringing the Arabs, which is very important because it has been mentioned throughout those days. At the moment, genomics is heavily contributed from Caucasian genetic ancestry. And as a bonus, the EGP has over 100,000 genome sequence on Oxford Nanopore, which is pioneering in the sense that it's not the technology that has been used in other programs to date, like UK Biobank and all of us. And this has some advantages as in terms of, for instance, structural variation, and also gives you information on methylation, which is a big plus for a genomics program.
Thank you. I think based on what I've heard from the gentleman, it's safe to say an investment into a population genomics program done the right way can generate unprecedented value. Paul, coming back to this topic around AI, we've had multiple discussions where we've talking about this learning system and building a learning health system. Now, AI models are fundamentally all about learning from data. Could you enlighten the audience a little bit more about what you mean by this learning system and how AI is going to augment and accelerate this learning system?
Certainly. Let me step back again and look at this big picture vision of interweaving different agendas together. So if we start with a research agenda that generates insights with the potential for application into a clinical domain, that's about knowledge transfer. That's about insights that need to be proven that they could be relevant for clinical applications. Now, as a rough rule of thumb, I think I'm happy to be challenged on this, but I think we understand probably about 1% of what's in the genome today. And so there's 99% left to be discovered that could be translated into the clinic. But even that 1% today is having a big impact in the clinic, and there are numerous programs that the gentlemen on this panel have been instrumental in enabling over the last years as we look at the clinical applications for the Emirati Genome Program. That's a wonderful start. But when you look at what happens when you do apply them clinically, it doesn't always transpire that you deliver what you expect. And those anomalies, those outliers, can sometimes provide a fascinating insight that could be fed back into the research domain. So it's almost like a knowledge cycle, an eternal loop of knowledge transfer. And for me, that concept at a systems level, in terms of linking the research agenda with an academic research agenda with the translational of that effort into the clinical domain, is an example of where a learning system can operate. And I think you can even describe it as a health learning system. And the question is, how do you capture the data? How do you look at the impact? How do you capture those anomalies, those outliers, and feed them into a model that will allow you to optimize and improve that system going forward? If you underlie that then with an economic development agenda where there's a vested interest in the development of precision medicines, again, where there is an opportunity to weave AI into the acceleration of the insights that can be generated, so you don't have to wait 20 years to get those insights that can be translated. You get those agendas working together, and you have the basis, I would argue, of a beautiful AI model, but you need the ecosystem around it that captures the outputs from each of those agendas and feeds them into the new agenda. So that, for me, conceptually is equivalent to what we're trying to do with AI at a practical level. If I then take just one of those agendas around the development of precision medicine, there are as we heard on numerous panels today already, there is an enormous potential just to use AI in terms of optimizing target discovery, looking at how you might design molecules more effectively, looking at using AI to optimize the clinical development process with clinical trials and patient engagement, ongoing monitoring of care, capturing the outcomes data that then might feed into a research agenda and direct that research to be productive more quickly in terms of future impact. So for me, the concepts of AI and the practical applications of them within each of those domains are instrumental. And at the highest levels, I would say there is the potential to accelerate all of these agendas through the adoption of AI at scale. But it needs to be coordinated, needs to be managed. We're not asking those different agendas necessarily to think about things in a different way. We just need a coordinating function that facilitates the interface between them.
Thank you, Paul. We started off the discussion by talking about the vast amounts of data generated. Genomics is generating vast amounts of data, but the one thing that isn't changing is when you're delivering healthcare or health, it is distills down to a 20-minute appointment that a doctor needs to synthesize all of the reports and the information available, evaluate a patient, and appropriately treat them. Albarah, over to you. At M42, we've got some tools which are augmenting this. Could you shed some light on some of these tools and how they're allowing genomics information to get into the clinic and for doctors to draw insights?
Thank you, Sid. I think one of the major challenges in the healthcare ecosystem is translating those complex clinical findings within the clinic in a seamless fashion to patients. So we took it on ourselves to develop a large language model called M42 that helps to take this complex information, and again, because you're limited by resources and limited by time, is how do you deliver this information, but more importantly, how do you integrate this information within the other clinical records? So a clinical genomics report is typically a standalone report that is very complex in understanding and very complex in translation. So by using M42, we simplify the translation of this clinical genomics report. But adding to that is we integrate it within the existing clinical records. So now we're able to look at the whole longitudinal assessment of the clinical records seamlessly, quickly, add to it the clinical genomics report, and give insights to our clinicians immediately to be able to translate that to the patients. What we see M42 is doing at some stage after extensive validation is actually even bringing it to the level of the patient. So how can the patient understand these complex reports? Because the limiting factor in genetics is those geneticists, genetic counselors, and physicians who understand the implications of these genetic reports, and democratizing this information that the patient now has enough information to make decisions, but in a safe manner, and that's the most critical element. The last element, which is still an aspiration, but is something we're working towards, is using AI models to find causal agents of disease from the environment. We're fortunate at M42 that we have a very large environmental science arm, that we test the entire environment on a daily basis for hundreds and thousands of molecules, creating tens of millions of data points per year. So how do we connect this and augment this to the clinical records, to the genetic records, both the long-read methylated data sets that helps us understand the epigenetics, the translation of the genome into disease, and find new causal agents of disease from the environment that are yet not understood. That, to us, is the next generation of what we're trying to do with AI, because these are very complex models. Sid mentioned that a whole genome sequence, what was your stat you used?
90 GB.
Sorry, 90 GB. Just to translate that, it's over 3.2 billion data points. So that's one individual has 3.2 billion data points. So imagine a whole entire population. So this is the complexity that we're facing, and we as human beings would not practically be able to decipher this data set. We require AI to do neural network generation of understanding this, as well as correlation and causal findings.
Also, I want to add to Albarah's point is that accuracy in diagnostic is very important. I know we have a lot of information out there in the web, but we have to be able to accurately sift through the information and to provide the information that is relevant for that particular patient. And sometimes we know that there are certain variants that might be pathogenic in Caucasian population, but may not be pathogenic in this part of the world. So we also need to look into that, and access to this POP genomics program that M42 is have started will help us to clear out the noise, speed up the diagnosis, bring AI to help you to basically merge this omics layers of data together. And I think this is a fascinating time to be alive, to be honest, that we are able to even sequence the entire genome within few days. 15 years ago, it would have taken you many months to do it. So we have to really take this opportunity forward and to be able to then apply this to the patients at the lowest cost, hopefully, and at the fastest time for the results to come out.
Great comments, Hemad. I think that's really critical. And what a program like the Emirati Genome Program has done, where we're sequencing almost the entire population, is to provide whole genome diagnostics available to a national population, which in turn will reduce diagnostic odyssey around rare diseases as well. So I absolutely agree with you. Javier, I want to come back to you a little bit. Albarah touched on it a little bit around the causal agents, epigenetics. Your team sits on a large amount of data, 780,000 genomes. Out of that, a good chunk is long read, methylation. This is a lot of data, a lot of different data sets. How do you think AI can aggregate all of these data sets, amalgamate them, and deliver deep insight, which initially probably helps in diagnostic yield, and then eventually looks into prevention at population scale?
Yeah, I think that, so with genomic screening, for instance, it's easier because maybe you have one genetic variant that you know it's related to the disease, so you go directly and screen that in the population. But as you add another layer of information, which is methylation, which is way less known than genetics, which also can change over time. So I think there you need more sophisticated models that are more computing intensive, that are maybe less agnostic or more agnostic to priors. And I think it's there where, with the explosion of AI, we're going to have a big benefit of this technological breakthrough.
Perfect, thank you. We've just run out of time on this panel. I think the message is loud and clear. The marriage between AI and genomics is here. In the next 10 years, you're going to see great advancements with both. As technology improves and we've got more compute, we're going to see genomics revolutionize healthcare and transition from healthcare to health.